All right, I see about 111 friends today. So let's go ahead and get started. Good afternoon. I am Stacy Abeleys. I am the Director of Development here at Pedal the Cause, and welcome to our panel today on emerging from COVID-19 and reemerging and rejoining society. We have an esteemed group of panelists here from Washington University School of Medicine here to speak with us this afternoon and hopefully answer all of your questions about COVID-19, how the coronavirus will impact us once we re-enter society and in the months to come for all of us in our community. So before we get started, let me go ahead and introduce our panel today. Joining us, we have Dr. Ryan Fields, Professor of Surgery and Chief of Surgical Oncology. Ryan, say hi. Wave.
Hello, great to
so
see
everybody
you.
Can see
all your faces and names.
Great. And next we have Dr. Catherine Glover Collins, who is the Assistant Professor of Breast Surgical Oncology Surgery in the section of Endocrine and Oncologic Surgery at the Washington University School of Medicine. Hello, Dr. Glover Collins. Nice to see you today.
Good afternoon. Good to see everyone today.
Great, thank you. So next on the panel today, we have Dr. Amy James, who is the Professor of Surgery in the Division of Public Health Sciences at the Washington University School of Medicine. Hello, Dr. James.
Hello.
Next, we have Dr. Joshua Rubin, Professor of Pediatrics and Neuroscience at the Washington University School of Medicine. Hello, Dr. Rubin. And last and certainly not least, we have Dr. David Warren, who is a Professor of Medicine in the Division of Infectious Diseases at the Washington University School of Medicine. Hello, Dr. Warren. Good. Well, let's go ahead and jump in. I do want to share that, again, you all are muted, but we want you to participate. So feel free at any moment in time to add a chat at the bottom of your box, and which is at the middle bottom of your screen where it says chat right next to participants. And Eleanor Gedicke, my colleague, and I will be looking at the chat box throughout and finding the appropriate place to enter in those sentiments. If we do not get a chance to get to you, or you have questions that you'd like to ask anonymously or privately, feel free to submit those to info@pedalthecause.org, and we will make sure that we route that to the appropriate esteemed panelists and get an answer for you. So thank you all again, and let's go ahead and get started. Our first question is for Dr. Fields, and that is, what do we need to know about the changes happening on May 18th and the re-entry officially into society?
Yeah, so I think, that's what everybody's sort of hoping, is that we've sort of come over the top of the mountain and it'll start to come back down. And part of that is really at the government level, both at the state level and at the local, more county or city level. And so, for the state of Missouri, there have been some relaxations in some of the restrictions that will be partially followed suit in St. Louis City and County starting really on May 18th. That'll allow some more businesses to reopen, potentially being in restaurants and being in society, but with restrictions of social distancing. So I think what everybody's really looking forward to is, say, going to their favorite restaurant again or being out and about again. But what we're all, I think, on the medical side and at the government side, trying to do that in a way that's both safe and where, if the best analogy I've heard is, we kind of have a faucet that's been off for a while, that we're going to open it a little bit and see what happens. But we really have to have a way to measure. If we open it a little too quickly, we can dial it back a bit. And that's where a lot of the things I think we'll talk about today related to getting back into society, of increased testing and contact tracing and what that means, and how that both affects essential things like the hospital and the clinic and going to your doctor's office or the dentist versus going to a restaurant or a shopping place. So I think we're all, but May 18th is when that's going to start happening more in our community.
Great, well, thank you. So to that end, Dr. Warren, when we talk about COVID and what it looks like, what have we learned over the past few weeks? And is it as much of a threat as we've seen moving forward as we move into, kind of rejoining society and stepping foot outside of our front doorstep?
Yeah, sure. So I think what we've learned is that all of the efforts that we've been doing in the St. Louis region with social distancing and with really the stay-at-home orders have really had a positive effect. When this started, one of the concerns would be that we would have, we didn't know what the outbreak would look like here. And we were obviously concerned about hearing stories from New York City and Northern Italy in terms of how severe things were. And so I really, really want to applaud people for all the efforts that they've done. Staying at home doesn't seem like it's much effort, but it has been. And as a result, we've been able to, at all of the hospitals within the region, and particularly at BJH where I am, have been able to manage the patients that are coming in and be able to care for them and not be in a situation where we don't have the resources we need or we are overwhelmed. So that has been a really positive thing. It still remains, that being said, it still does remain a threat. I think in terms of how this virus spreads, it's a respiratory virus, and it still can be spread through through coughing and through contact with other people's respiratory secretions. And so we still, just because there's nothing magical about May 18th, I think one of the things we need to do is make sure that we keep our guard up and really try to practice the sort of some of the habits that we've developed over the last month or so.
So we got a question from one of our board members that I'd like to ask, because I think based on both Dr. Fields and Dr. Warren's responses, I'd love to know from a physician's perspective, what do you worry most about reopening? And what things are you going to do in the near term to be best prepared?
Josh or Catherine, maybe you can answer that, because you'll be seeing and are seeing patients now and will be part of that ramp up.
So I think, one of the things that I worry the most is that people will not take these precautions that we've already put in place, like social distancing and wearing a mask, to heart, and that, we'll see an upspike. So I think, we really want to make sure that our patients know that the measures that have been put into place that have kind of helped us to keep our curve down still need to go forward, and that, we be cautious when visiting these places and ramping up our business or seeing patients.
Yeah, I would echo that. I think among the things that I worry about is people not being energized by how great the effort has been and how successful it has been to be social distance, stay at home, wearing masks. We've had a huge impact on what's happened over the past couple of months. And I think that we should be, applauding everybody's effort and encouraging people to continue to make that effort until the risk is as small as it can possibly be. And, particularly within a community of families in which there are individuals being treated for cancer, we have to set an example. We've done a great job. We should continue to do a great job.
And I would say one thing I would echo, this May is Skin Cancer Awareness Month. I take care of a lot of patients with skin cancer, and one of the things we're trying to emphasize is that the doctor's offices, in particular Siteman and WashU, have gone to great lengths to make that a safe place to come if you have a medical problem that needs to be addressed. So what we don't want are people to put off their medical care that is needed or concerning because of this in the situation where we can make it a safe environment. So, you can't really get into the medical center without being screened. You can't get into the operating room without being tested for coronavirus. You don't come to clinic without wearing a mask and things. So we're trying to make that emphasize too, that the general medical care, whether it's your heart disease that you might have or a new concerning skin lesion, that shouldn't be put off because of this right now. And we're trying to have strategies to really minimize risk.
Great, thank you. So kind of to that end in patient care and advocacy from a caregiver perspective, Dr. Glover Collins, can you talk a little bit about, for those patients being currently treated at Siteman, are there any new procedures for treatment for surgery patients that need to be followed? And can you talk a little bit about kind of that community of family and friends that may want to be with them at that time, and what is being allowed as far as visitors and or you know, someone to be with a patient who might be undergoing a procedure at this time?
Sure. And Ryan actually kind of already touched on some of it. Universal masking did go into place all across BJH institutions. And so, you know, we encourage patients to wear their mask, their cloth masks from home if they have them. And if they don't have them, then of course we are providing masks to our patients when they come on campus. There is an extensive screening process that goes on before you even come for your clinic visit or for your surgical visit. And then you will also be screened once you get there. So, you know, there are, all those measures have been put in place. In terms of surgery, you know, for elective surgeries, procedures, and even for emergent and urgent cases, we are testing patients prior to surgery. And we're asking that once you do get your testing, that you self-quarantine until you do have your surgery. And then the people that you plan on having visiting with you also self-quarantine so that you don't come into contact with patients or potentially infected people with COVID-19. And then as far as bringing family members, you are allowed one visitor in the clinic setting so that we can try to minimize the number of people that are in the clinics.
So as we talk about just safety in general, I think there's probably a lot of questions about not just entering businesses and place of work, but also school is ending very soon. And in the state of Missouri, obviously children have been learning from home. And I know we probably have a lot of parents on this Zoom that are going to be very interested in the next few questions. And that is, with school closing, you know, for many in the next few weeks, what are safe activities for children this summer? And, you know, Dr. Rubin, I'll ask you, you know, when we talk about activities, obviously that's anything from day camps, whether they're residential day camps or sleepaway camps, and or, you know, pools and any other activities. What is deemed safe for you know, our youngest kiddos, and what do parents do with them all summer?
As a parent, I'm also facing this question. I have a 15-year-old who goes off to sleepaway camp every year, and it's what she looks forward to all year long. I'm not sure that camp is going to happen. I think the first principles are the same principles we've been talking about. Anything that compromises your ability to be safely distanced, compromises your ability to be certain of, we're going to talk about contact tracing soon, but be certain of what the network of individuals are that constitute the contact network of individuals that your children will be in contact with, are all pose risks. There's no two ways about it. There are risks. I don't know which camps will even be open, but certainly, or public pools, and I don't know what the rules will be at pools and parks. Maybe somebody else on the panel is more familiar with this, but it's going to be up to parents, myself and the rest of you, to be exercising our best judgment about what the risk is for our children. Obviously, the safest thing for them would be to stay at home all summer, but that is a hardship in so many ways for parents and children alike. And finding ways to either have a network of friends whose exposures and whose isolation, like in my neighborhood, everybody was quarantined for a long time, and now the kids in the neighborhood are actually playing together. And I think for the most part, that's been a well thought out, supervised, and relatively low risk activity. But I think the first thing will be exercising those standard precautions and using good judgment, and remembering that regardless of what the state says, and regardless of what your mayor says, and regardless what the federal government says, you ultimately have the responsibility for weighing the risks against what you know are the appropriate protective measures. I don't know if other people have comments on that.
I guess I kind of, as a parent whose child goes to a sleepaway camp in northern Michigan, that camp has been talking about a strategy of bringing all the staff in 2 weeks before the camp starts. They all get tested. Nobody comes or goes from camp. All the kids get tested 2 days before camp. The first week of camp, they wear masks and social distance and test every kid again at camp. And then if everything is negative, then they basically have a nobody comes in, nobody leaves, but they open up camp and it's a 4-week, 5-week sleepaway camp. And then have a system in place so that if somebody were to develop a fever or symptoms, they have kind of a quarantine area. So I guess my question would really be maybe to David too. Do you think that weighing risks and benefits, that would be sort of a reasonable thing to do, to have in my mind, it's almost better than having them go to a day camp every day and come back and forth like they're in their own little area, own little world.
Yeah, no, I mean, I think, that sounds like a fairly aggressive plan.
Yeah.
I think, what we know about COVID is that there are some people that are either have very mild symptoms or have no symptoms. And then also the incubation periods of the time from when you're exposed to when you have actually potentially have infection can vary. It's around anywhere between 2 to 14 days. Most people, it's like 5 to 7 days. So I think it's it's a fairly aggressive plan. Anything we do, there's going to be some risk. I think that one sounds fairly aggressive, but there's always a chance that something could happen. And so I think, again, you have to balance the risks and benefits of everything, and think about how, as your own situation and kind of what your personal risks are, and then kind of make those decisions. But as Josh was saying, we're kind of in charge of our children, and even as they get older, we're still ultimately the ones that make the decisions.
Absolutely. Thank you. And so one of the follow-up questions I would have when we talk about summer plans and activities, whether it's, a child in local residential camp or sleepaway camp, is, whether we're getting to sleepaway camp or getting on a vacation. Can we talk, Dr. Glover Collins, a little bit about traveling, and is it safe to fly, and what are we thinking as far as leaving St. Louis for the summer? What guidance are you giving, or what discretion should people have, or considerations when thinking about travel, either to get a child to and from a location and or for personal travel?
Well, I think a lot of it has already been brought out again about contact tracing and being able to stay or have practice safe social distancing, and I think that Ruben brought out a good point about knowing who your children and you are in contact with, and that network of people, I think will be really important. I think ultimately it will be safe to travel as long as you can continue to practice some of the standard precautions that have been put in place. I saw on the news a few days ago where the social distancing was basically not possible on the plane on I think it was a United Airlines flight. And since that aired on the news, you know, a lot of the airlines are putting different mechanisms in place to allow for social distancing, and I know the airports are also doing fever checks and screening and things of that nature. So I think, you know, the onus is ultimately upon us as parents to determine what is safe for travel. But I know that everybody is in it trying to make sure that we put different procedures in place to make travel as safe as possible.
Thank you. So we've heard this term used a couple times on the panel today, and that is contact tracing. So Dr. James, can you talk a little bit about what contact tracing is for those who may not be familiar, and also, you know, maybe about some of the technology? We'll be able to use our phones or other technology to help us do that in the future. You know, if you could share a little bit, that would be helpful. Thank you.
I will answer that, but I'm sure Dr. Warren can build on my answer as well. I mean, contact tracing is really about when someone is identified as having COVID-19, tracing back the people who have had contact, you know, extended contact with that person and potential exposure during the time when the person was infectious. So it's a way of trying to contain the spread of the virus by figuring out who might have been exposed. And we've done this for other infectious diseases for a long time. It's really a ramp up in our abilities to do this to the extent we do for coronavirus. So it is, you know, once someone's identified with the virus, finding out who's been in contact and potentially at risk, and then testing those people and getting them to quarantine so that the spread is contained. In terms of using phones and other technologies, there have been some countries that have developed apps for this and procedures for doing this through whose cell phone was next to whose cell phone for how long and when. And doing so in ways that protect confidentiality, because we don't just go around and name who got sick and that. So I haven't seen any indication that the technology-based approach is taking hold here in the United States. I think we're doing a little bit of kind of old-fashioned, I don't want to call it old-fashioned, but legwork. And finding out who's who. And that gets to the point about day camps and summer camps and going places, is knowing who's been there. And does the group have the ability to track that? Dr. Warren, do you have anything to add to that description of contact tracing? Not to put you on the spot.
I had a little trouble hearing the audio on there, but you know, contact trace, like Dr. James said, contact tracing's been used for years to track infectious diseases. The ones that particularly that people think of are things like tuberculosis, and then smallpox was also something that we would aggressively contact trace. I can tell you that, you know, the states have gotten money specifically to ramp up contact tracing. I know Missouri is hiring basically people to do this, and a lot of it is really just good old-fashioned footwork and really talking to people and finding out who they've been with, who they've been in contact with, and then following up those individuals and making sure that either if they are sick, obviously that they get appropriately tested and potentially quarantined, and the same thing if they're a contact, that they're at least aware of what happened, that they were exposed, so they can take precautions and they can be aware, and then also restrict their activities so they don't run the risk of spreading infection to other people. I think as opposed to SARS, which is one of the other novel coronaviruses that we had to deal with almost 20 years ago now. This virus, people can actually shed the virus earlier in their illness. As opposed to SARS, where it was only several days after they were feeling sick that they were more contagious. So it's really important to track the people as much as we can. And I think that's one of the things that is really going to be important as we kind of emerge out of this, to try to keep this from coming back.
Sorry, didn't realize I was on mute. Thank you very much to both of you. Follow-up question, Dr. James, would be, as we're talking about May 18th, people are starting to figure out what they're comfortable with, and one of the areas that has probably been hardest hit, one could argue, is hospitality and restaurants. And so restaurants are taking a lot of steps for people to feel comfortable not only picking up curbside, but eventually to make their way inside the restaurant and dine. So what precautions should one consider taking? Wearing a mask, gloves, what are your thoughts around dining out?
That's the big question, right? I think probably some of us are tired of home cooking and would love to go out and enjoy a restaurant meal or support the industry. I think it's what's been said all along, is keeping your guard up, being careful, definitely keeping the mask on, although you have to take it off to eat. So you have to navigate what you're comfortable with if you're going to eat inside the restaurant. See what the space looks like, and is it socially distanced. Gloves only get us so far, because we're just as likely to touch a surface and touch our face and touch things with our gloves as with our hands. And hand washing is really better than anything else. Making sure you wash your hands before you touch things you're going to eat, before you touch your face, is the way to prevent that. The other part of this that I think is important is, it's not just what we do, it's what the people around us do. So if you go someplace and you be careful with your mask, but people around there are not, then that may not be the ideal situation. So I'd say keep your guard up, be careful, wear the mask as much as you can, social distance, and make sure that distance is there, and then figure out what you're comfortable with in there.
Thank you. So kind of, again, moving forward, moving out of the home, people will be returning to work, and this question is really open for anyone. So for those who are returning to work on May 18th, I mean, we trust that our employers are doing what's best for us, but if we want to ourselves be vigilant, how long can the virus remain on a surface, whether it's the kitchen counter in a communal kitchen, a door handle to the restroom, how long is the virus there, and what steps should we be taking to ensure that we're going above and beyond the normal cleaning routine to protect ourselves in the workplace?
Yeah, I can answer that. I mean, I think, if you look at some of the studies and you hear the news, people say, oh, this virus can last for a week on certain surfaces and a day on cardboard, and et cetera. And I think one of the challenges is trying to interpret some of those studies. Those studies are done in labs where, kind of in ideal situations, and also with a large amount of virus, potentially larger than what you would expect in kind of the real world. So they're not dealing with, ultraviolet light from the sun or other things. That said, I think, they're, especially at home, what we've been doing is making sure that people, clean, sort of wipe down the high touch areas that they come in contact with, like light switches and countertops and handles and doorknobs. And this virus is not particularly resistant to a lot of disinfectants. This family of virus can be pretty well inactivated by most household cleaning products and bleach and sort of normal disinfectants that you would kind of get over time. So I think using those disinfectants, and then when you're out, thinking about having something like alcohol hand rub, which is very effective. Also, you look for the 60% or greater alcohol hand rub. That's effective, and so that's something that you can take with you if you're out and about to kind of disinfect your hands, because that's really, for these sorts of viruses, that's one of the primary ways they spread. We touch something that is contaminated with the virus, and then we touch our eyes or our nose or our mouth, and so making sure that you avoid doing that, for one, but then also using everything that Dr. James was mentioning, using good hand hygiene, cover your face with a mask. And that serves two purposes. That somewhat protects you, but it also protects everyone, because like I was telling you before, there are times where people are not really necessarily having symptoms, particularly early in the infection, where they're shedding virus, and the mask is really a way of limiting that. And that's something that we've done for decades in the hospital when we have someone who we suspect has a respiratory infection that like the flu, we put a mask on them and we wear masks to protect everyone.
I would really echo too what David had said about the hand washing part, because if you touch something that's contaminated and it's on your hands, you're not going to necessarily get the infection until you touch your eye or your mouth or your face. So if you have an Amazon package on your front porch and you bring it in the house and you open it, well, then the first thing you do is wash your hands after that, so that if on this very off chance it was a package that was laced with coronavirus, you're going to wash your hands and the problem's not going to get into your body with a high degree of certainty. So it's still really the hand washing, and as David said, the masks. And I think if you kind of pick two things that we're doing and we can keep doing, like don't let up on that, that would, I think, continue to make a huge difference in limiting little outbreaks turning into big outbreaks.
So one of the questions we received through the chat was about a spouse going back to work when the homebound spouse has a suppressed immune system. Can we talk a little bit about the extra steps you take? I mean, you're all physicians, and you work outside the home in a place where the virus is very present. Can you talk to us about the steps this person should consider taking, but maybe that you are taking when you are entering foot back in your home where you have family and children, and just what are you doing to protect them, and what should maybe this person consider doing and sharing with their spouse to keep their household safe from potential interaction with the virus? I'll open that to anyone. Sorry if I wasn't clear.
One of the things that I do, especially on days that I operate, is I, number one, wear different clothes to work than what I bring into my house. So I have a change of clothes that I change into before I come home. I also make sure that I wash my face and hands before I go in. Some earlier articles even advocated for wearing scrub caps so that our hair doesn't come in contact with things. And you have to be careful when removing these items that you're not getting all of that on your hands. But when you do remove them, again, as Ryan's pointed out, wash your hands immediately. That way that you have the least amount of virus coming into your house.
I think that one of the advantages that we have is that we work in an environment in which the risk is mitigated by all of the precautions that are required to step onto the WashU campus and all the testing that will be done of patients and staff. I think the real problem is for people who work in environments where all those precautions are not routinely taken, and in which there are employees that might not take any precautions outside of work. And in that case, while there's the direct sort of contamination risk, bringing virus home on your clothes or your hands, there's the actual infection risk, somebody becoming infected because they go to work and then coming home and infecting individuals at home. As in all things, everything is the balance between being safe and the extent of the hardship. I mean, the question that's in the chat box is really a painful question of a family that is separated because of an immunocompromised individual and a newborn and a spouse that goes to work someplace where maybe precautions aren't taken. I don't know if David has any, specific guidelines. My heart goes out to that family. And, I guess the one thing I hold on to myself is that with proper precautions and measures as we've been taking, presumably the risk of getting infected is going to decrease with time. And so whatever we're doing now, hopefully, is temporary. It's a hardship, but it's temporary. It's not necessarily the way that we will be living in the months to come. And if there's any comfort in that, then maybe that's part of the plan.
Yeah, I mean, I think it is a challenge, and that is a difficult situation, especially because, the individual, the spouse that's working outside the home is working in a place where it sounds like people aren't really taking precautions. And that could be, it may be, and I don't know enough, whether it's the nature of the work that they do that makes it difficult, or if it's certain people in the workplace are just resistant for some reason or another. Either way, one thing would be to consider having a discussion with their supervisor, obviously offline from everyone else, and mention some of those concerns. Because if one possibility is if they're having those concerns, then potentially other people in the workplace are having similar concerns. And so that may be a way to kind of improve the environment. But it is hard because, I think you can take some of the precautions that we talked about to try to reduce the risk. Obviously, stay away from people that are ill. That's an obvious one. But then, all of the things with hand hygiene, trying to keep your distance as much as possible, wearing a mask. Those are all the things, but it might be worth having a discussion with one of the supervisors to really have that discussion.
I mean, I think we saw the ultimate failure in the meat processing industry, where they had a totally unsupervised and non-social distancing work environment with a lot of people in very close contact and a lot of shift workers working together, where they had these huge outbreaks. So I think that, it kind of shows you that if you do nothing, there's the potential for disaster. Whereas if you have a good screening process in place and a work environment that would allow for social distancing, it's probably going to be a safe strategy to come back to work, especially with good contact tracing and the ability to say, oh, somebody tested positive. Now we know everybody that was with them in the last 5 days, and they can quarantine, and we can keep it, to a small number of people that get it.
Absolutely. Thank you all. I think that was really helpful. And if there are, again, continued questions about this, please continue to add them to the chat box. We're kind of monitoring that. And a lot of the questions are actually echoing the next two sets of questions that I have, and that is about testing and a vaccine. So Dr. Warren, can you talk a little bit about the latest news in regards to testing and antibody tests, and when and if they'll become widely available? And do you have a thought on a time frame? And inquiring minds want to know.
Yeah, sure. So I'll talk a little bit about the antibody testing.
Thank you.
So initially, the FDA, when antibody testing came out, it kind of had it took a different strategy than what it did for the actual virus, detecting the actual virus. And a lot of companies came to market very quickly. And really the question would be, some of those tests weren't necessarily the most reliable. And so the FDA has kind of changed their course and has kind of put some more restrictions on and some requirements for these companies. So I think we'll start to see that have an effect in terms of which products are available. At BGH, we have one particular test that was emergency approved by the FDA for this purpose. I think the challenge with the serology tests are, and what I tell people is, this virus didn't exist in humans 9 months ago. And so it's entirely new. And one of the things are, we don't know what the antibody test results for an individual person mean. We don't know, does that mean you're fully immune? Does that mean you're somewhat immune? How long does that last? I think those are all questions that we really don't have answers to yet. And the other thing is, like any test that we do, there are the chances for false negatives and false positives. And I think, you know, and especially even though we've had, you know, a fair number of cases in St. Louis, we haven't had as wide a spread in the community as, say, New York City or Manhattan has. And so in populations where there's not as many people who have been infected, you always run the risk of a positive test result being more likely to be a false positive test result. And so that may, you know, that's something that we have to think about too. I think the role of serology, there's always been a role that we've looked at for kind of figuring out who in a population's been infected. I think we're not there yet for making really hard decisions about who is immune and who can do this or who could do that because they're immune, because we just don't know. We just don't know enough yet about the serology tests to really say that for sure. I think, you know, time will tell, and we will get, as we go through this, we'll learn more, and we'll learn more about what does that really mean in terms of immunity. But right now it's a little early, but hopefully as the time goes by, we'll get firmer answers on that.
How about on the vaccine front? Any new updates?
There are many people, both here at Washington University and really around the world, who are working on vaccines. We have one of the researchers in our division who is very active in looking at vaccine. There are several candidates that are starting to go through the clinical trial process. As many of you know, probably from just dealing with cancer, there's the way we do sort of approve something, and first we have to prove that it's actually safe, and then we have to prove what dose is really effective and what does effective look like, and then we have to figure out, once we figure out that dose, is it protective? And so that all takes time to do. Obviously, everything is very accelerated because this has become a global priority. So, you know, if you listen to Dr. Fauci, one of the comments he made was that probably, you know, at the earliest, probably by the end of the calendar year, will we have something. But that, you know, we'll have to see. But I can tell you a lot of people both here and really around the globe are working on that problem.
And for the immune suppressed, when can cancer patients, you know, safely use the vaccine, or is that something that demands further testing, or what are the thoughts around looking at additional safeguards for those who have a cancer diagnosis?
Sure, yeah. So a lot of the vaccines that are being tested right now aren't what we call live virus vaccines, and particularly in people with suppressed immune systems, live virus vaccines can be a problem. So most of the vaccines that are being tested now are not that type of vaccine. So that, I think that will potentially make it more available to individuals who have, problems with their immune system, either because of, underlying cancer or chemotherapy. I think one thing is we'll just have to see sort of, again, because people may not have, their immune system may not be working as well, how well they mount a response to the vaccine. And that's going to be something that we will have to see. I think, it's what as an infectious disease doctor, one of the things that I always tell people is the whole concept of protecting people who are vulnerable in our population for one reason or another is to actually make sure that you vaccinate everyone around them. If they can't be vaccinated, then everyone in the family can be vaccinated. And sort of that way you help protect them. And so I think that may be, depending on how things go, and again, that's all conjecture, but that's going to be potentially an important strategy.
I would just add, just from the point of view of an oncologist, I know that patients frequently want to know how long are they immunocompromised after treatment and when can they get vaccines. And so, as Dr. Warren was saying, there's two considerations with regard to immunosuppression and vaccines. One is whether the vaccine will be effective. If you're too immunocompromised, you can't generate an effective immune response to the vaccine. And then there's the risk, live virus, live attenuated virus, bacterial vaccines. These propose risks for the immunocompromised of getting sick from the vaccine itself. The general guidelines for us, for patients who have received standard cytotoxic chemotherapy, is generally around 3 months after treatment. They can mount a good immune response to a vaccine and are relatively protected against live attenuated vaccines. For those who've had bone marrow transplants, the time is longer. We routinely think about a year. Sometimes it's longer than that. There are ways of assessing immune response to common antigens, like doing skin tests for response to things like common yeast and other things can tell you something about the state of somebody's immune system and can guide how you think about delivering vaccines. But the specific answer, for an individual who's immunocompromised is going to depend on which of the multiple vaccines that are currently in trial emerges as the vaccine that will work. And as Dr. Warren said, figuring out which of the vaccines actually are effective and effective over time and how effective they'll be will be important considerations. Keeping them safe by controlling their exposures is really the best approach that we have.
I mean, as an oncologist and not a vaccine specialist, but knowing how long it takes to take a therapeutic like a vaccine from a early stage study to make sure it's safe to finding a dose to effectiveness, it was amazing to me to see that, for example, a company like Pfizer has a vaccine that's now being tested in humans in Germany and in the US in a very rapid time frame. So hopefully we'll really know safety soon. And like Dr. Fauci and Dr. Warren had said, by the end of this calendar year, hopefully have something and have companies like Pfizer and others with the capability to mass produce something more rapidly than we've ever seen before if it's deemed to be a success.
Yeah, so one of the questions that we got as we were talking about vaccines and testing is, infants. Dr. Rubin, can we talk about, our youngest members of society? One of the questions was about what are the risks for infants, under 12 months. So can we talk a little bit about that and their risk?
Sure. Obviously, we have an enormous experience with vaccinating infants, relatively newborns. I think that we know a tremendous amount about how to do that safely. And I think as the vaccine clinical trials move forward and the vaccines that emerge as potentially protective are identified, and the experience in the clinical trial setting for their activity and their safety, will be able to come up with guidelines for vaccinating infants. I think that, you know, among the things that we may have to consider is this emerging post-infectious vasculitis that's been in the news this past week, and who among young children are really going to be at risk for that if it turns out to be truly be related to COVID. And whether or not that would influence the way we think about the vaccination schedule, in much the way it influenced the way we thought about the vaccination schedule for Haemophilus influenza, which used to be an awful infection for newborns, and which we don't see at all anymore because we stack a bunch of immunizations very early in life against it. I don't know, David, do you have other things to say about that?
Yeah, I mean, I think it's like you said, Josh, it's going to be really, we'll have to see in terms of most children who have gotten infected have had fairly minor illness compared to adults, especially to older adults. Infants, there have been infants that have been infected, and there have been some that have had severe infections. But I think, like you said, we're trying to understand that potential vasculitis that's associated with infection. If it is present, it's rare, but you know, that is something that will have to be considered, and thinking about what's actually causing it. Is it some sort of immune response after infection?
Thank you. So one of the questions I received via chat, again, as we're talking about testing and vaccines, obviously there's a lengthy potential timeline for rolling out a full litany of vaccines. So what is your comfort about opening up the world without a vaccine? And kind of, you know, your thoughts on, you know, another wave or anything that we can anticipate in the fall and winter months without a vaccine present.
So I would love to hear, I mean, obviously, if we have a treatment, then the requirement for a vaccine might become less. We don't have a vaccine for HIV, but we have effective treatments for HIV. I'd be interested in hearing your thoughts, David, about where we stand with a treatment.
Well, there is one drug that's gone through a clinical trial that was actually, the trial was stopped early on the Recidivir, that showed, it's an IV treatment, and showed some, it didn't show a mortality benefit, but it probably wasn't powered to do that when they discontinued the study. It showed a trend towards it, but no statistical significant benefit, but it showed a significant reduction by about 4 days in terms of hospitalization. I mean, obviously the challenges with that are it's an IV drug, so it's not an oral drug. So, and then the other thing is that kind of the population that they used was relatively healthy, or you know, so we don't know how it'll do with a wider variety. And also there's a supply issue because you know, the company is rampant. This was originally a drug that was developed for Ebola as a potential treatment. Then there's other things that, as you probably heard, the post-convalescent serum. So they take people who have had COVID, they donate serum that has the antibodies in it, with the thought being that you transfer some of their antibodies to someone who's very sick, and then that will help with fighting the virus and improve their condition. This is really an old method of what we call passive immunity, and it was used in the pandemic in 1918 for influenza. There are ongoing studies looking at this. There's one that we're doing here at WashU where we have had people who have volunteered, who have been infected, who have volunteered to be plasma donors. And we're looking at, those studies are all ongoing. There probably does look like there's some benefit, but one of the things are trying to figure out which part of the immune system is really the most effective at fighting this virus. And so that makes the assumption that it's basically antibodies. It might be the T cells, for example, that might have a role. So we're kind of learning more of that as we go along. And then the other possibility of that would be, could we make monoclonal antibodies and find, are there particular antibodies that are very effective against the virus that neutralize it? And so could that be one avenue? And then I think there are studies that are ongoing now looking at drugs that are already FDA approved for other indications and seeing if they can be repurposed to treat this. I think, the thing that people always think about is hydroxychloroquine and with azithromycin. As we've gotten more data, hydroxychloroquine doesn't really look like it necessarily has effect and that we would like. So, but there are other drugs out there that potentially could be used, and so part of that is before we do that, we actually need to study them to make sure that what we're seeing is real, and really do it in a controlled manner, so we can really draw stronger conclusions about whether or not to use it.
I feel like, Stacy, to get at your question a little bit too, I think without a vaccine and without a real home run effective therapeutic, the way to still have some degree of getting back into society safely is with more widespread testing and with good contact tracing and social distancing to stay in place, because again, then you can identify people that have it and where they had it and know who they were exposed to, number one. And number two, if you're able to do that, you can follow these metrics of, the idea of like this R factor and our cases going up or down in a particular area once you relax a certain metric. So can you continue if things are going well? And that I'd be curious as to other people's opinion on that R factor, where if it's 1, it basically means for every infected person, they're infecting 1 person. If it's less than 1, say it's 0.5, then they're infecting less than 1 person by a half. And if the number was 2, that means or 1.1 even, it's higher. So that for every 1 person's infecting more than 1 person, there's still growth. And so that seems to be a real good metric for determining if what we do is safe or not.
Right. So we are right at the top of the 1 o'clock hour. We did have a couple of questions that unfortunately we were not able to make our way to, so we will share them with the doctors and share them either on social media or directly back to those who asked those questions. But again, I just want to take the time to thank all of our esteemed panelists for joining us. Obviously, there's a lot of interest in what it looks like to emerge back into society after COVID-19, a lot of which we're still learning. And so we know we don't have all the answers, but we appreciate all of the information that you were able to provide to us today. So again, I'd like to thank Dr. Fields, Dr. James, Dr. Rubin, Dr. Warren, and Dr. Glover Collins. And again, thank you to everyone, the 130 some of you who joined us today to learn more about the coronavirus and its impact on all of us. And as we rejoin the community, I'm Stacy Abeles with Pedal the Cause. Thank you for joining us today. A recording of this video will be available on social media in the upcoming days. And if you had any questions that were not answered and you'd like to follow up or have a question yet to be answered, please email that to info@pedalthecause.org. Thank you all for joining us today. Have a great afternoon. Wear a mask, be safe, social distance, and thank you. Have a good day. Wash your hands.
You all.
Like
Be
your
safe.
mom said, wash your hands.
Thank you so much.
Thank you, everyone. Have a
Bye.
great day. Bye-bye.
Thank you.